Happy St. Patrick Day. Let's start with it. Today, we are almost in the end of our session. Today is the week 11, and for today's topic, we have end of life care, location of care, last 48 hours, how to manage patient in last few days, and when to stop definitive treatment. And our speaker for today will be Dr. Natasha. Today case will be presented by Vidya Badal. Today host is Sanskriti and facilitator is me, Dr. Sani, and our co-facilitator is always there, Dr. Sudhir. Key learning point will be collected by Sushma Gurung. Question and answer in chat will be answered by Peter and Dr. Shak. And timekeeper will be Sanskriti and Indu. Regarding today's speaker, Natasha Datu is pediatric hemato-oncologist and palliative care physician working at BC Children's and Kanak Place Children Hospice in Vancouver, Canada. Let's start with her presentation. Please go ahead, Dr. Natasha.
Thank you, Sunny. So we're going to talk about compassionate care in the last 48 hours of life, and hopefully you'll feel more comfortable managing children who are dying after some of these topics. Next slide. So we're going to use a case. This was a child who I took care of and review the last days to hours of their life. And we'll talk a little bit about treatment near the end of life, more physical symptoms and how to manage them, including medications, how to communicate with families near the end of life, as well as how to support decision-making around the location of care, as well as post-death care. Next slide. So these were topics that were previously covered in ECHO sessions. And so we won't be talking about these, so you can refer to the videos from our previous sessions about these topics. Next slide. So I just wanted to remind people that we've talked a lot about pediatric palliative care and how pediatric palliative care doesn't only mean end of life or terminal care. We like to become involved if possible early on for any child with a life-limiting illness. But today we will truly be talking about terminal care and end of life care. Next slide. So we'll go through the beginning of the case. So this was a 16-year-old female who had a history of brain and spinal tumors. She was diagnosed 6 years ago and has gone through various chemotherapies, surgeries, and radiation. The palliative care team has been involved for the past 3 years to help with respite as well as symptom management. And she has had recent progression in her tumors. They've grown and she has had functional decline in the last 4 to 5 months. And these are just some questions that I thought about when I was taking care of this patient. We're not going to go through them today, but just for you to think about in the future if you're ever reviewing the case. Next slide. So the patient and the family had a meeting with the neuro-oncologist to review options for chemotherapy orally because of her progression. And the goal was to slow the tumor growth and prolong her life. The family was very aware that the disease was no longer curative, and the palliative care team attended these meetings to help support family and oncology. Next slide. So I just wanted to remind people again that the palliative care team in this case was able to very naturally attend these meetings with families because our team had become very much involved early on as the disease was actively being treated, but we were helping with symptoms. And then sometimes, of course, we do become involved in these patients if they cannot be cured. And so it was a natural, easy transition for us to become more involved with this patient. That's why we like to become involved early on for any child with serious illness. Next slide. So how do we decide on treatment decisions or disease modifying therapies near the end of life? We have to balance hope with realistic expectations when we're offering these therapies. We know that active treatment, usually in the form of chemotherapy for cancer patients, is the most common thing that becomes an issue in these situations. We know that treatment can always be given together with good symptom management and the involvement of palliative care. And we should always try to have palliative care members join some of these discussions to be able to hear the information that families are being told. But enhanced communication is also a skill of palliative care teams and people who are supporting palliative care. And so it shows families that we can all work together and travel both of these paths together. Next slide. So as an oncologist who also does palliative care, these are some of the ways I think about what treatment to offer families when children are not curative and becoming more and more sick with their disease. I think about their performance score. So this is how sick the patient is and what functions they can still do. I think about the goal or the intent of the treatment. Near the end of life, the goal should never be to cure or change the course of the disease. It can be to prolong life, to prolong good quality of life. And sometimes with certain types of cancers, some chemotherapy can improve symptoms such as bone pain and leukemia. I think about what are the current symptoms and how are we managing them? And I think about the risks and benefits and trade-offs of treatment. If a family doesn't want their child to be in hospital, it may not be appropriate to offer IV chemotherapy that would put them in hospital. Next slide. So this is a palliative performance scale, and this is a scale of 5 different physical areas that I sometimes use and the adult palliative care teams use in North America quite a bit to help us see how sick a patient is in an objective way. It is not prognostic in pediatrics, but there are 5 areas. The first is ambulation. How mobile is the patient? The second is activity and evidence of disease. What are they able to do still? The third is self-care. What activities of daily living? Can they toilet themselves? Can they get to the bathroom? Or all those all require assistance? The fourth is intake. How much eating and drinking are they able to do? And the fifth is their level of consciousness. How awake are they? And as patients go through at 100%, they are very robust. And as we go down, they become more and more weak or fragile. Next slide. So when we think about this scale, when patients are up at the top between 70 to 100%, usually they're quite robust, they're strong. Giving treatment makes sense in these situations sometimes. When we get to the middle, patients are getting a little bit sicker. And we need to think about if treatment, active chemotherapy, will help them or will it actually make them sicker? And these are discussions that are often needed to have with oncology and palliative care, as well as other treatments such as neurologic conditions or cardiac conditions. When they get to the end here, less than 30% on that scale, I mostly do not find that treatment will benefit patients at this stage. Next slide. So back to our case. So the family wanted to try some oral chemotherapy to help the patient's disease stay from progressing. Within 1 week, however, the patient had a decline in her function and she wasn't able to swallow as well. So the oral chemotherapy now would require an NG tube. And we knew the patient did not want an NG tube. So we had another discussion regarding trade-offs, and the family and the team all agreed that it was too much for the patient. And so we did not want to give her any chemotherapy through the NG tube, but we left it open and provided hope that if her swallow improved, of course, we can reconsider. Next slide. So the patient had a further decline, and now she had been admitted to the hospice on a Monday for the family to have a break. And for them to get some respite and for us to care for the patient. On this day, she was able to communicate. She had some verbal language and she was pointing and eye gazing. She was still eating some amounts orally. She really liked yogurt. She was voiding and stooling. She was smiling. She was able to visit the garden in her wheelchair. Next slide. However, 5 days later, now by Saturday, the patient was not verbalizing as well. Her ability to communicate was decreased. She was fixing her eyes a little bit more, and she was not as alert. She was more sleepy. So I wondered, was this medication? Was it infection? Was it her disease? Next slide. So these are some of the most common symptoms at end of life. Physical fatigue is very common. Pain, poor appetite that Dr. Peter talked about last week, nausea and vomiting, swallowing, bowel and bladder, and shortness of breath. So we will address some of these today. Next slide. So as we've talked about in previous echoes, all of our pediatric palliative care symptoms can be assessed and managed in a stepwise way. We want to assess the patient, treat any underlying causes if appropriate in the last 48 hours of life. We want to help as we can with non-pharmacologic therapies. And then of course we have medications that can help. Next slide. So the first symptom we'll talk about is sedation or level of consciousness near end of life. Next slide. So patients often become more sleepy in the last few days to hours of life, and this can be very distressing to families. And it's helpful to explain that this is a protective measure as the body transitions closer to dying. It's often related to an increase in carbon dioxide in the brain and also sometimes increased intracranial pressure from neurologic conditions, tumors. And it's helpful to acknowledge to families that time is getting shorter as they see this. But it's helpful to remind them that their family and their loved one can still hear, smell, feel them. So it's important to be present, to talk, read, sing, pray to them. All of this provides comfort to the dying child. Next slide. In terms of medications and how to support patients who are getting more sedated, we can switch medications from a different route. If they're taken orally, switch them to any other route, IV, subcutaneous, rectal, or sublingual or buccal. Continue with mouth and eye care. We need to change position for patients who cannot do it on their own. And sometimes families do ask about decreasing sedating medications. So if patients are on infusions of opioids or benzodiazepines, families often wonder if it's the medicine that's making them sleepier. And sometimes we do try to decrease medications to show families that most of the time, it's usually the disease that's making them sleepy. And so it can be helpful for families if we try to decrease the medication. Sometimes the patient will not wake up and that shows them, or they wake up and they're uncomfortable and we have to go back up on medications. But I just wanted to explain that as that sometimes happens. Next slide. So another symptom near end of life in terms of neurologic symptoms are seizures or neuroirritability. Small seizures do not necessarily need treatment at end of life, but if they are generalized seizures, they're causing distress, benzodiazepines are usually the first line treatment for this. And I've given you the doses and the different medications here. And sometimes phenobarbital can also be helpful in these situations. Next slide. Another common neurologic symptom near the end of life is terminal delirium. And this is when a patient becomes more confused, they're restless or more lethargic, and they can sometimes have hallucinations, either visual or auditory, they hear things, and sleep can be very disturbed. This is more common in the adult population, but we do see it in our teenagers, and it does often precede death. So I explained to families that this is often caused by changes in the body during the dying process, less oxygen to the brain, less fluid, lower kidney function. Next slide. So how do we treat delirium? Provide a quiet, calm environment, ensure the patient is safe, and counsel the parents that it's not helpful to correct the child if they're confused, but listen to them, cuddle them, make sure that they know you're present, and this can help orient, soothe them, and make sure they're not scared. Next slide. Pharmacologic management of delirium. Often we can try rotating our opioid. If they're on morphine, you could try hydromorphone or fentanyl if you have those available to you. Otherwise, antipsychotics are very helpful. Things like Nozinan or methyltrimeprazine, Haldol, Haloperidol, or things like olanzapine can all be very, very helpful in these situations. Next slide. This is a medication resource for you. I've starred anything that will be helpful for you to review doses and medications. Next slide. Pain can also be very common at end of life. If patient is verbal, you can ask them if they're having pain. If they're nonverbal, you look for the face, grimacing, are they calm? Or are their hands clenched in a fist? Or are they relaxed at the bed if they're nonverbal or more sedated? And opioids are your first line to treat pain. And these are your doses here. Next slide. This is a tool that we can use sometimes if patients are nonverbal, but they are awake, to ask them how much pain they're in or the location of their pain. They can just point sometimes, and we can draw this with a pen and paper and have it at the bedside. Next slide. This is another medication resource for you to review if you need for pain resources. Next slide. So if you recall, we're back to our case. Our patient has become a little bit more sleepy. She is not able to communicate as well. And the parents are worried she's not eating, and they're worried she's hungry. There had been lots of discussions about an NG tube. We know the patient did not want one. However, today, she was actually able to communicate and say she was willing to try an NG, hoping that she could have small amounts of food for comfort. So we did insert the NG. However, a few hours later, she felt it was too uncomfortable and it was removed. So I highlight this because sometimes we have to try things to show families that it's not the best option. And so that's what happened in this situation. Next slide. So 3 days before the patient died, she's now become very sleepy. She's not able to communicate. Her breathing is regular, but shallow and more slow. So we asked the parents what their observations were, and they had expressed they felt their child had changed and they were worried she was dying. The team agreed with the family, and they felt that time was also shorter based on the changes that we had seen in terms of level of alertness and her breathing changes. Next slide. So how do we communicate with families near death? All bodies usually go through the same changes near death, whether it's cancer related or non-cancer related. Families do appreciate honest information, and we should always ask permission to review the changes you would expect ahead of time. There is often a clear pattern of change to show death is near, and we should never give time. We should never make firm predictions, but instead giving time spans based on your observations of clinical change. So usually hours, we think hours to days, days to weeks, or weeks to months. Next slide. This is a really helpful sheet you can review later to give to families about how to talk to them about death. Next slide. So these are some of the more common patterns of respiratory changes we see near end of life. So often this is due to the body slowing down and less oxygen being delivered to the brain and the centers that control breathing. And so I explain that to families. And usually we see respiratory status changing. So slow breathing, becoming more irregular. Then we start to see short pauses in the breathing, seconds, longer pauses in the breathing, sometimes minutes. And then patients do have what we call apneas. pauses or stopping to breathe, and then eventually a terminal apnea. Secretions can sometimes become more loud because the tone of the body is lower. And we treat this if it becomes more, if they're having distress. So if they look dyspneic, if they look like they're struggling to breathe, we treat that. However, sometimes the medications can actually cause the body to become more calm and the noises can become louder. So I warn families of that. Next slide. So these are the non-pharmacologic measures of dyspnea that we've reviewed before. Make sure the environment is cool, open a window, use a fan, and try repositioning the patient, as sometimes this helps if the breathing is quite loud. Just changing position can help. Next slide. Next slide. Oh. Thank you. So pharmacologic management of respiratory distress or dyspnea is the same for terminal care as it would be for patients who are less close to death. So opioids are first line, morphine, hydromorphone, fentanyl, whatever is available to you. If they're not on an opioid, we start at 50% of the dose you would use for pain. But if they are already on an opioid near end of life, you would titrate to effect. Second line is benzodiazepine, and the doses are here. Next slide. So I wanted to mention what we call terminal orders, and these are depending on the location of care. If a patient is in hospital or hospice, these are orders that the prescribers or doctors order that can be helpful to treat severe pain or severe symptoms in the last minutes of life that nurses have so they can help make the patient comfortable. Usually it's an opioid and a benzodiazepine, and usually it's either IV or subcutaneous route if those are available. And it's usually a higher dose than their regular scheduled dose, either the same dose or higher in a shorter time interval, every 10 to 15 minutes as needed. Next slide. So this is just an example of the terminal orders I had written for our patient in terms of I've written for you what her weight is, what her regular dosing is, and what the terminal orders I have ordered for the nurses to be able to use if the patient was actively dying to ensure their comfort. So you can review those later to see if you would have written similar orders. Next slide. So now we're the next day, 2 days before our patient died, and the nurses noticed some longer pauses in her breathing, and she intermittently had coolness to her fingers and toes. Parents had noticed she had more pallor, she was more pale, and her body felt more limp. The changes were communicated to parents, and they voiced that if time was short, they wished their child could die at home. Next slide. So perfusion or color changes in the last hours of life are quite common. And again, this is the same principle that the body is slowing down, the heart is slowing, there's less oxygen being delivered, the body can become more pale, it's cool to touch, but this can fluctuate. The change in color, the feel can all get more or less, and this doesn't mean the patient isn't dying or the patient is improving. The pulse rate slows, and there can be pooling of blood and looks red or purple in gravity-dependent areas. Next slide. So the location of care at the end of life. In general, there are 3 common locations that a patient or child can die: the hospital, the hospice, or home. And these are all dependent on various factors, and the teams that are taking care of these patients should all have open communication with families in discussing this. It depends on how sick the child is and how severe their symptoms are, what medications are needed to treat their symptoms and ensure their comfort, the route of the medications that are needed, the anticipated or expected symptoms the patient may have closer to death, as well as cultural or context that depends on the location that you're in, and how available the team is in terms of phoning families, what mode of communication is able to be had in terms of supporting families at home. Next slide. If a patient is going to potentially be home, We always need to anticipate symptoms and plan for them so families feel comfortable, and we make sure the patient is comfortable near the end of life. So these are all the symptoms we anticipate, and we need to have resources in the home to care for families. Next slide. So these are some common medications we have in the home, and we can teach families with the supportive teams if they're able to do home visits or phone families. I always like to have a benzodiazepine, an opioid, as well as some type of antipsychotic, such as methyltrimeprazine or Nozanan, if that's available to you, to manage delirium, sleep, nausea, as well as something, if possible, to manage secretions, either atropine or scopolamine, if that's available to you. Next slide. So we managed to get our patient home from the hospice, and the team from palliative care was doing home visits and regular phone calls. So 6 hours after the patient got home, the family phoned us with noisy, loud breathing, and the patient was in a lot of distress. We arrived in the home about 10 minutes later, and the patient had loud gurgling, very loud breathing. She was dyspneic. She was very much in distress, and she had pauses and lots of secretions. We treated her with subcutaneous opioid, morphine or hydromorphone, as well as a benzodiazepine, such as midazolam or Ativan. The patient did settle after quite a few doses, and we pre-drew syringes for the parents at bedside and reviewed how to give the medicine, when to give the medicine, and to call us if needed. Next slide. So the next morning, the patient had an okay night, and we visited in the morning. The patient was now having much more breathing changes. She had more irregular breathing, what we call seesaw breathing. She was having longer apneas, almost 30 seconds, some noisy, gaspy breathing, but no distress. And she was very cool to touch on her hands and feet, but her abdomen was warm, and she had some pooling of blood on her arms. Next slide. The palliative care team did a visit at the end of the day, the same day, and now her apneas were minutes. We gave 1 dose of subcutaneous opioid to calm her breathing down, and the patient was no longer responsive, and her body was very cool to touch and almost had a grayish color. At that time, the mother noted that a bird had hit the window a few minutes prior. We left and the patient was comfortable, and we got a phone call, and the patient had died 20 minutes later. Next slide. So I did want to mention what we call a principle of double effect, especially for the nurses who are often giving these medications to patients who are near close to dying. And this is when we have an intent of giving a medicine to relieve pain, suffering, but sometimes the side effect of the medication, which can be to stop breathing, happens. And we need to be very aware of this because it can be distressing to the doctors, the nurses, the family, the whole team. But we need to remember that the intent of giving the medication is to alleviate suffering, and it was the right thing to do to give the medication. And the disease process itself caused the patient's death. The medication did not cause that. And so it's helpful to have open communication about if this happens near death. Next slide. So what to do after the child dies? Depending on the location of death, I do remind people there's no need to rush to listen to the heartbeat to pronounce death. It's very respectful and very okay to allow the family as much time with the body. You can sometimes look at the clock to know what time the patient stopped breathing, but be mindful that terminal apneas can take a bit of time, especially in babies. And so they may have a gasp minutes after, and to be aware of that. And sometimes the heartbeat can continue after the breathing has stopped. And so if a baby has died, I often wait quite a while, 10 to 15 minutes sometimes, before listening for the heartbeat. And I go back and listen a second time again. We can, if appropriate, remove lines, tubing. We can bathe the body, and any rituals based on religion or culture can be discussed with the family in those moments. And then we often have the discussions of where the body will go depending on the location of care and where you are working and where your patient has died. If your program or if you have the ability to have a social worker or counselor, of course, this can be helpful to a family. And bereavement care post-death can be helpful for a family. Next slide. And I did just want to mention that sometimes, often families will tell us about signs that they have seen or felt close to their child dying. This family noticed a bird had hit the window and then the child died 20 minutes later. Another family had told me they saw a shooting star and their son died an hour later. And another family told me they saw a ladybug crawl up their daughter's arm and on the hospital bed, and she died that night. And they continue to see ladybugs all over when they think of their daughter. So I hope that this presentation gave you the practical pieces to help care for children and their families as they're dying. But I think one of the most important pieces in terms of caring for dying children is to be present and to connect with families, because this is a privilege and this is something we can all do, is to be present and listen and hear the family stories. And so hopefully this was helpful to you. Thank you.
Thank you, Dr. Natasha, for such a wonderful presentation. Discussing end of life care is always hard, but with honest discussion with family, we can deal more easily, and with further communication will be good with the family, and dealing will be much easier. We'll be taking questions at the end of the sessions. So we'll move on with the presentation. For today, our case presenter is Vidya Badal. She is a staff nurse working in Kanti Children Hospital. Please, Vidya, go ahead with your presentation.
Thank you, Dr. Sunny. Good morning and namaste, everyone. My name is Vidya Badal. I am a staff nurse at Kanti Children's Hospital in Oncology Unit. I am going to present the case for today. Next slide, please. The key questions for today's case presentation are end of life care, location of care, last 48 hours, how to manage patient in last few days of life, when to stop definitive treatments, how to teach family to manage the child at home. Next slide, please. For the patient details, the child was 6 years old, male child with the diagnosis non-Hodgkin's lymphoma, diagnosed on 30th October 2020. Other diagnoses were intestinal obstruction, DIC, and peritonitis. Next slide. The treatments and significant investigations done were the child was on chemotherapy, child was kept NPO with nasogastric drain. CT scan was done on 5th February, showed small bowel obstruction likely due to adhesion, mesenteric lymphadenopathy, hepatomegaly, splenomegaly, minimal left pleural effusion. On 30th October, biopsy was done of cervical lymph node on left side that suggested of non-Hodgkin's lymphoma. On 9th March, PT was 20.1 with INR 1.17 and control 12. APTT was 63.6 with control 28. On 10th March, USC was done, which showed hepatosplenomegaly, GB sludge, and moderate ascites. On 30th March, CBC was done, which showed platelets 5,000, WC 1500, polymorphs 2 on 25, lymphocytes 23 on 25, and hemoglobin 8.6 mg per dl. On RFT, urea was 25 mg percent. Creatinine was 0.4, sodium was 136, potassium 4.8, and calcium was 9.3. Next slide, please. On holistic assessment, pain and symptoms, including relevant treatments, were he developed intestinal obstruction during the treatment. There was severe pain in his abdomen, managed with frequent administration of injection morphine. Abdominal distension was present. There he had bleeding disorder and also developed seizure one episode. He was malnourished. Other supportive treatments given were injection vitamin K, injection liberacetam, injection morphine, calcium gluconate. Blood transfusions were done multiple times. PRBC, FFP, PRP, and platelets were transfused. He was also on antibiotics. On the psychosocial and family concern, the child belonged to the remote village in far western region of Nepal. The father worked in India as a laborer and used to visit home few times a year, and mother stayed at home with three sons, including the child. The child had two elder brothers. They had spent all their savings on child's treatment and also had taken loan for it. They did not have any other economic support nor health insurance. They were worried about the expenses, yet they wanted to comfort their child by any means. Next slide. The parents were concerned about the prognosis, treatment outcomes, and pain management. The mother was more concerned that the condition of child would be better if he could be fed by mouth. On their spiritual concerns, they followed Hindu religion, had strong belief in God. They prayed for the child's recovery and had offering in temple. They believed this condition of their child was due to their karma. Next slide, please. On the assessment about communication, the father was aware about the condition and prognosis of the child. However, he wanted to continue the treatment. The mother had hoped that the child would get better if he was fed by mouth. In her view, he was weak because of he was kept NPO. The child used to communicate about his pain and asked for analgesic. He constantly expressed his wish to eat food. In a later stage of life, the child thought he was going to die and talked about it with his mother and the nurses. The parents were counseled about the condition of the child and discussed about the withdrawal of the definitive treatment and continuation of supportive treatment only in the later stage of his life. Mm. About the collaboration and partnership, the parents of the child, the oncology team of doctors and nurses, dietitian, physiotherapist, team of surgery department, psychologist, volunteer and supportive organizations were involved in the treatment of the child. I want to summarize the case. A 6 years old male child with diagnosis of NHL developed severe abdominal pain and distension associated with intestinal obstruction. The child was kept NPO for almost a month. He had poor nutritional status. Child was on IV fluid with parenteral nutrition. There was nasogastric drain for decompression of abdominal distension. He had one episode of seizure and developed DIC in later stage of life. The parents were counseled about his condition and DNR consent was signed. The child was shifted to a private room where the parents could spend time with their child in peace. Definitive treatment and invasive procedure were withheld in last 48 hours. The mother fed the child soft rice by mouth on the last day. The key questions for today's discussion are how to provide enough life care, how to manage patient in last few days of life, last 48 hours of life, how to discuss end of life care with parents and patient and family, where can be a location of care, when to stop definitive treatment, how to counsel parents to stop definitive treatment, how to teach families to manage the child at home. This is my case for today, and I want to thank you all.
Thank you, Ms. Badhu, for such a nice presentation. We would like to hear from faculties regarding the key questions. Dr. Krishna, would you like to put some your experience?
Thank you, Dr. Sunny. Thank you, Natasha. Very nicely covered the topics and case experience also very good. Regarding the experience of the end of life care in pediatric in our center, we do Initially, we have explained the patient about the definite treatments. So once they know there is no more care, just like uh, stage 4 disease and not respond to chemotherapy, not able to do surgery. So by that time, it takes a long times with the parents, with patients, with their family. So uh, we know we cannot cure it, and we slowly convince the parent, and that's how we are preparing the patient for end of life care and stop the definite treatment. And as a parent who do not want to go home, they we shift them in the hospice and palliative care setting. And there, the team of the all the team multidisciplinary team is taking care of the patients. And last moments, maybe 48 hours or maybe few days. So child initially we never force for the IV fluid and other things. We just want ask the parents what I'd like to take, what they want to offer, maybe little bit, not to force the feeding. Sometimes we think, and then we do not want to continue the IV antibiotics and active treatment. Even sometimes we just do not force them. Sometimes parent want to give the blood transfusion, just like in leukemia, lymphoma. When the child is very anemic, so we never force them. And last hours, they know parent they are already prepared. The child is not going to care another palliative setting, and even team know we do not do much different treatment, but lots other adjuvant just like treatment, pain medications, and body care and care of the bed. So oral care, body care, it's all they are doing when continuously, and sometime they do some type of physiotherapy and some mobilization if possible, in and out the ward around, and what child like to see or what like we offer them. And that's why after shifting the palliative care, the our team and we are just targeted to the preparing for other things, this end of life care. And in last moment, just like Natasha covered very well, the child in our center, mostly parent complain about child dyspnea, and sometimes oxygen they offer wants to offer oxygen. So we do give sometime for some time, maybe 1 liter 2 liter, and by that time we again talk with the parents, and then it doesn't help much. So slowly we are not comfortable to continue this. And last few days child do not want to even take foods, and child becomes slow, bedridden, and I look like almost closing, and even boil bladder is not sometime incontinent, sometimes it's not regular. So parent used to bother on that, but we counsel them. This is the we are to at the end of life care. So maybe these are normal for they are not taking food, not taking liquids, and then their body slow and their activities decreasing slowly. Then we used to make them comfortable as far as possible. Sometimes child sleep for longer, and ultimately at the end of life care, the mostly the respiration and child, if there is no pain, there are no other IV fluids, other things, so child respiratory pattern slow down. Even intermittent looks like intermittent, and peacefully most of the child is to die in the bed. So at that time, even parent is just quite happy. Even they ask us to present there. Even after death, our team sometimes meet together, and sometimes even parents they are losing the child, but they greet whole the team. Even and some of the child used to do some of the craft or they some prepare something during the end of life care. Sometimes some parent and some even child asked to give some gift to the team after their death, like that they prepare just a flower and a handicraft, something what they prepare. Sometimes it is very heart touching for us, but even they know they are going to die. Parent also expected, and we try our best to make them death peaceful. So this is some experience what I have in our center. Maybe other people can have the different idea, maybe different experience. So maybe nurses, especially nurses, we do not stay longer in the end of life care in the patient side. So maybe the nurses who are caring in the hospice, they are there whole time, 24 hours, and they may have their better experience than what I have, maybe what I feel in that. So maybe some of the nurses can share their experience, so how exactly they feel and other thing, that we are intermittently being there and support, observing and supporting them only. Thank you.
Thank you, Dr. Krishna Sagar. As Dr. Sagar says, any nurses staff can put their views regarding the case, regarding their experiences. Anyone? Angela?
Do
Angela?
we have you?
Or
Sunny,
from any other centers?
actually, the care was done pretty well, but maybe the family, like we have the concern about the mother that she was persistently saying that the child was not being fed well, and then maybe he was hungry. Because of that, the child was getting weaker. So maybe she needed persistent counseling and like orientation about the disease process from the very beginning. And also, like she needed to be reassured, so that and the child also wanted to have the feeds. uh, so in that time, like maybe the mother as well as the child could have been you know explained better. I don't know, you must have explained, but then maybe it should have been started earlier. And then if they wanted to take the child home, or I mean, that option could have been kept open, I guess. They might have chosen to stay at hospital at the end of life, but maybe we could have given them an option whether they wanted to take the child home or something like that.
Hello? Thank you, Angela. Uh, Dr. Vishnu was looking after the case. We would like to hear some word from him. Dr. Vishnu.
Thank you, Dr. Sunny. First of all, about the disease, it was a peripheral T-cell lymphoma. It's a very rare disease, and nobody knows how to treat this actually. And there are only trials, and we can try medicines. Uh, so one protocol was already tried, and that had not responded. Then we switched over to another protocol. Before that, the child developed intestinal obstruction, and the surgery consultation was done. As Megan has pointed out, what could have been done differently? We could have done palliative intent surgery, but that was refused by the parents because they didn't want anything aggressive. And then we changed the protocol, treatment regimen, hoping that the new regimen would work and perhaps would relieve the intestinal obstruction. While doing so, the child developed TIC. After he developed intestinal obstruction, we put NG for decompression, nasogastric tube. And the child would ask for feeds. And we actually tried giving him sips of black pea, or very sips that would not turn solid. And whatever he would have would come out of the drain, and his pain would aggravate. The child actually would keep chocolates with him and eat when everybody was asleep. And then his pain would worsen and he would need more morphine. So we had actually given that small liberty to the mother. We had explained it to the mother that whatever we give, it may worsen the pain, but if he is very much willing for it, you can give sips. And the biggest problem was whatever he would eat, the abdominal distension would increase, his pain would increase, and the thing would come out of the NG drain within less than an hour or so. That was the problem. And we could not get a surgery. So that was a big deficit here. Another thing I would like to clarify was we do not have total parenteral nutrition facility as of now in our center. And that was one reason why his nutrition, his malnutrition was getting worse and worse every day. And in the part of counseling, the parents were counseled about 3 or 4 times on separate sessions with good time given to them. And what we explained to them, one important thing was that this is a rare disease and this is all we can do in Nepal. There has been no deficiency in the care from the side of the hospital and from the side of the parents. And that was importantly, we highlighted that parents have done whatever could have been done, and there is nothing else that they could have done, and they are not at fault for the child's condition. It's just that the disease is very rare and the treatment is not known. So, when he got sick, and we shifted him to a separate room, there were 4 beds, we kept it empty, and we let the mother keep the child in his and we deferred any invasive or aggressive treatment. We did not shift the child to intensive care unit. We explained to the parents and they agreed to it. So in last 2 days also, they were together and the child took his last breath along in the parents' lap. Thank you.
Thank you, Dr. Vishnu. Any other faculties would like to put some views? I guess cameraman could say something regarding the case and end of life care. Cameraman.
Hi, thank you so much. And I just really appreciate, Vishnu, your reminding us how hard this work is, reminding us that even though we have lots of knowledge and lots of medicines and lots of things, we still do not know enough. So thank you for that. And thank you for the case. Yeah, I guess that's all I want to say is that we shouldn't get used to thinking that end of life is easy. This is a very, very important part of parents' lives, and we need to treat this with such kind of awe, I think. And I really appreciate my colleagues there in Nepal doing such good work. So thank you.
Thank you, cameraman. Any words from any other faculties before closing the session?
We have Dr. Aruna with us. Can she highlight few of the issues in the Southeast Asia, typical issues encountered while dealing with the end of life care? Dr. Aruna? I think she is not with us. Anyone from the Hyderabad team? Okay, and actually we would like to hear more from the nursing side. Imal Soba sister, are you there? Imal Soba sister? Sabita Panthi sister? Anyone from the nursing side, especially from the Bharatpur who are working in the hospice, they would like to highlight a few issues that they have felt or experienced while dealing with the end of life care. Okay, we still have another day to go, another session to go, and we would like to hear from the nursing side more in the upcoming session. Dr. Sunny, please continue.
Thank you, Dr. Sudhir. I think if there are no any other faculties more, we should continue with this session. And today is almost we are at the end of the session. Thank you everyone for being participated, and thank you for the session. Thank you.
Okay.